We're gonna get started. So the title of the talk is New Year, New You. This is a little bit different format because most of the webinars that we host at Rothman are basically a surgeon or a physician speaking to the audience about a particular problem. This is a little bit unique in that we're actually having some of our patients speak to you and hopefully answer some of your questions. And while there isn't the ability to ask questions on the webinar, please use the chat that Les was going over with you, and I'll show you how to do that when it's time. But if you have any questions, feel free. We'll try to answer some of those online, and some we will try to answer with the patients replying. So a little bit about me. I'm an orthopedic surgeon. I've been in practice since 2004. I'm the director of adult reconstruction at Rothman, and adult reconstruction really is hip and knee replacements. I do over 600 hip and knee replacements every year, and I'm located at, gosh, I didn't realize I was running around to so many places, but I'm in Bensalem. I operate there and see patients there. I only operate at Jefferson Hospital. I don't see patients there. I see patients at Newtown, as well as the Bordentown office in New Jersey. And I also operate at a center called MOVE in Warminster, Pennsylvania, and also when our MOVE center opens in Bordentown, New Jersey. So that's a little bit about me. More importantly, there's a whole team that helps take care of patients, whether they're surgical patients or patients that we're treating conservatively. And teamwork really does make the dream work. And these are three vital members of the team. Moy Kang is the nurse that works with me. Marilyn Malinowski is the nurse practitioner that works with me. And Rebecca works in the OR with me, helping me out. But there's so many members that aren't named here: the anesthesiologists, the medical assistants, all the people behind the scenes that make your care hopefully seamless. So the agenda for this is fairly straightforward. We have a patient, Sean Gill, who had a hip replacement with me recently, and Dwight Ely is a bilateral knee replacement patient who had his surgery coming up on 4 years now. And they're here to share their experience with you. So you hear what the experience is, not from a physician or a surgeon, but from a patient who has been in your shoes where you are now. Here's how to answer your questions. So if you're on the chat, if you're on the webinar here at the very bottom, you'll see a chat button. All you have to do is press that chat button, and you can type a message right here. If you hit enter, it'll come through to us, and we'll try to answer as many questions as possible. To respect the time of Sean Gill and Dwight Ely, we want to stick to the time frame. So at 7 o'clock, we're going to have a hard stop. But again, this recording will be sent out to you, and hopefully you'll find it helpful and educational. So we're going to start off with Shawns' story. Shawn is 64 years old. He has a lovely Irish accent. I love whenever he comes into the office. It just makes me happy for some reason. And he had long-standing hip pain. So Shawn, why don't you tell us what your experience was like? What led you to come into the office the first time?
I am a self-employed plumber. I work for myself. And for the past 3 years, I was getting a pain in my hip. And it got so bad that when I would be driving my truck, I would have to try and raise the left-hand side above the seat. The pain was that bad. So then I started sitting on a heavy cushion. So that didn't help either. And whenever I would come home at night, I would sit down for 2 or 3 minutes. I'd have to stand back up again. And then I found out that it started affecting my work because I'm always kneeling down, trying to get underneath the sink, whatever. I would have to hold on to the countertop to get down and get back up. So it was just really sore, and I couldn't walk too much, which I love to do. So my wife had a hip done many years ago. So I had been up at Rothman before getting work done on my foot 3 or 4 years ago. So I decided to go back up there and find out about getting a new hip done. And I was really amazed at how quick I was able to get it done. And I was more than amazed and happy about the results and how I feel now.
So thanks for sharing that. Where was your pain? You know, a lot of people say they have hip pain, then they kind of reach towards their lower back.
Okay. The, the pain that I had was where your where the top of the hip comes onto your bum or whatever you call it, right? That's where it was paining me a lot.
Yeah,
And
so like sort of buttock pain.
yes, and I was taking maybe 6 to 8 ibuprofen every single day, and that didn't seem to help.
Wow. So some people do have buttock pain like you do. Lots of people have pain in the groin and
Yeah,
maybe the top part of their thigh, and that's one of the more common presentations for hip arthritis. So,
yeah,
you saw me in the office, and these are actually your X-rays, Shawn. So
yes,
if you look over here, can you see the arrow there that I'm pointing
yes.
to or not? So on the left side of the screen, that's actually your right hip. And you can see there's a space between the socket and the ball there. And that space really is cartilage.
Okay,
And when you lose that cartilage, you get the appearance that you see on the left side where there is no space between the bones there. You also
yeah.
have a lot of bone spurs in the area out here. And so that's what we would call, bone on bone arthritis. And it's certainly not rocket science. You look, there's no space. The bone literally is grinding against the bone, which was giving you the pain. So ultimately, when you come into the office and you say, "Oh, I'm having a lot of pain," a lot of people are wondering, well, what was that sort of aha moment where you said, "Listen, I just can't live with this anymore"? Was it a moment for you? Was it a series of things? Like what drives someone to say, "Listen, I think I need to get this fixed"?
Okay, the reason I said I'd get it fixed was this had been going on for about 3 years, getting worse and worse. And it was even getting to the stage, like I said to you, if I was up standing, I would stand up for 5 to 10 minutes, I would get the pain, then I'd sit down, get back up 2 3 minutes later again. And even driving, like I actually drive down 95 every single day and sometimes stuck in traffic for an hour and my left hip paining me. I trying to lift my hip up off the seat just to feel relaxed or comfortable. So I said, I have to get something done with this. I am young and I also still work for myself and I don't want to be taking ibuprofen many every day, which is probably not good for my stomach. So because I was so happy with Rotman before, I said, let me go up and talk to one of the doctors up there. I went up, I got the x-rays. He saw it was bone on bone. And he said, there's two things. We could either give you some cortisone injections, which I know that's only temporary. And I was so happy with another surgery up there. I said, let me decide about getting the hip done. And around the holidays, it's always quiet for us. And I would have some downtime. So I said, why don't I get it done? I might as well take the bull by the horns and just get my hip done and have time to relax over the holidays. And I just feel this is the best thing I ever did.
It's great. And what were you most worried about, when saying, "Okay, I'm going to go forward with surgery"? What was one of your bigger concerns, and how did you get that addressed?
I was worried in the sense that when you hear about a hip operation and you hear about them cutting out a piece of bone, and I never had a piece of bone cut out before, I said, oh my God, what's going to happen? Will I have one leg longer than the other, short or whatever? But I always have problems. And I just said, I'll just get it done.
All right. So this is what we did for you. So on the left side of the screen is the implant that we use, and basically what we do when we do a hip replacement is we take a titanium socket. Titanium's great because it's a pretty inert metal. There's not much reaction to it in the body other than bone loves to grow into it. So this is a porous coated implant, and bone grows into that socket. And so you see that on the X-ray here. Uh, that's
Yeah.
right there. That's the socket that's actually in your hip right now. And then you can see a little shadow here. That's the plastic liner that goes inside that titanium socket.
Okay.
Below that is the ball of the femur, and that's usually made out of a ceramic material. And then there's a titanium stem that goes inside your femur here. So you have the titanium shell, you've got the plastic liner, the ceramic
Okay.
head, and the titanium stem here. And bone grows onto that at remarkably regular rates, and it should provide you fixation for the rest of your life. One of the concerns sometimes people have is, hey, it's not going to last me the rest of my life. And the best part about one of the best parts about hip replacement these days is the plastic that we use is very durable. And at least we know, at least at 15 years, the wear rates are so low that certainly a hip replacement done in your 60s or even your 50s could last the rest of your life. Of course, there's a lot of factors and you can't guarantee that, but the data is looking really strong right now, as opposed to prior to the year 2000 when the plastics weren't as good and they would wear out a little more quickly. And Shawn, you mentioned you lost some bone, and that's true. If you look here, that's the femoral head and that's the neck. And what we do is, because since they're arthritic, we have to sort of cut them off, and basically they are replaced by this stem that goes into your femur that holds onto the ball here. So those are your x-rays. And you want to tell us a little bit about your recovery thus far? I mean, I would consider you still in recovery because your surgery was only in mid-December, but you want to tell us about what the hospital stay was like and what you've done since that time.
Sure, DM. I went in and I was in the hospital for 2 days. DM, the operation went great and so on. The only thing that I couldn't understand was from the lower part of my body down, it was numb for a day or two, and I actually couldn't feel my feet on the ground, which is probably the nerve block. And as I said, so I was in there and I was doing my physical therapy, and now and then I'm a very strong person in the sense that, number one, my wife is always saying, you can't sit easy for 5 minutes, but I have to get up and do something. So when I was in MOV, I would actually get up and I'd walk out into the hallway on my own, just to move around, because I figured rather than just sitting down, if I can move the joint slowly and just start getting it back together again. So I was in there for 2 days. I came home, and when I came home, I started doing my physical therapy. For a few days, I wasn't in a lot of pain. And again, I'm the type that I don't like to kind of take painkillers, but for the first few days I did. And after that, I had so little pain, I just took acetaminophen.
That's great. And how long did you use a walker or cane?
I used a walker just to come in the house. And I would use it a little bit around the house, and that's it. Maybe, I'd say a total of maybe 4 or 5 days, that's it. And then I used a stick for a little bit, but other than that, I didn't feel I had to use anything.
Got it. And I'll translate Irish for everyone in the audience. A stick is a cane. That's what our European friends commonly call a cane, which is a stick.
Yeah. No, I actually had a question which you had before. Naturally, the bone has to grow in around this joint. Would it help? I used to take a lot of vitamins. If I start taking calcium, would someone recommend that so the bone would grow better or stronger? Or
yeah, so that's a great question, and it's a common question people want to know the answer to. And from what we know in the literature, the answer is no. You don't really need to take calcium. That's a separate issue from osteoporosis. And so osteoporosis is very common in folks who get hip and knee replacement surgeries because in general they're a little older.
Yes.
And so it's a related issue in that sometimes when you're doing a replacement, the bone may not be strong enough to hold an implant that is cementless. And sometimes we use bone cement to get fixation into the bone, particularly on the femoral side, to avoid fracture. But it is very important for those who are of the age where a hip replacement may be indicated or a knee replacement that you talk to your physician about osteoporosis and being evaluated, because it's a big problem in this country. But in terms of the implant having bone grow onto it, doesn't appear that calcium or other supplements at this point are really necessary unless someone has a metabolic disorder.
Okay.
So Shawn, we're gonna come back to you. Obviously, when I saw you a month out from surgery, you were walking with hardly limp and doing wonderfully. So thank you for sharing that experience. I'm gonna flip over to Dwight's story here, and then we'll get to some of the questions that are coming up on the chat. So Dwight, at the time he had surgery, was a 58-year-old farmer. He's the owner of Ely Farm Products, and if you're in the Newtown area, I highly recommend going there. He's got some wonderful products, but he came in with knees that look like this. And so similar to the hip, you see a decrease in the joint space here between the femur, which is up top, and the tibia, which is the bone on the bottom here. And then there's the fibula, which is the smaller bone out here, which isn't really involved in the joint per se. So it's bone-on-bone arthritis. And just in comparison, these would be normal x-rays where you see a lot of space between the femur and the tibia. Everything looks sort of clean, right? There's no bone spurs or anything like that. So that's what a normal looking joint would look like. And here are Dwight's knees again. So Dwight, thank you for joining us. You've always been a wonderful patient, and we're happy to have you on. Will you tell us a little bit about your story? What kind of brought you into the office? What sort of treatment did you have before you decided to take the dive into bilateral simultaneous knee replacement surgery? It's a huge step.
Okay, well, my story started back pretty much in college. I was on a wrestling scholarship, so I wrestled and had some serious knee issues wrestling. I had a total of 3 knee surgeries in 2 years, and so I was taken out of the sport by the surgeons. They said no more wrestling, and but they honored my full ride for 4 years, so that was a real blessing. But I ended up, coming back to the farm and starting the meat business. And my father, I'm 8th generation on the farm, so my father sort of commissioned me with trying to figure out the next generation here on the farm. So I decided to set up the meat business, and everything went really well, except I was super active, and I used to do all kinds of sports. I played tennis a ton. I did water skiing and barefoot skiing and all kinds of stuff on my knees post my surgeries down in college. And I did a lot of hiking, climbing, rock climbing and stuff. And eventually my knees started to really hurt again. And I slowly started eliminating those active things that I did. And my kids were getting older. I have 3 awesome children that were getting older and wanting to do these things. And I do some hunting, so I do a lot of hiking, and basically slowly I was getting moved out of the opportunity to do these things with my family. I have a very young bride. She's 32 years my bride right now, but she was young and athletic. She was a great athlete herself. And it just got to the point where I was the one who was not able to kind of keep up and do these things. So with a great knee pain, ultimately I heard some, I asked people, and everybody's got a word for you, but Rothman and Austin kept coming up, and I'm like, hey, I need to check this out. And I was extra blessed when I heard that I could just go right to Newtown and have an appointment there, which, for a busy guy, that was huge. I didn't have to go down into the city, find parking, do all that deal. So went right into Newtown to the office, was seen, and doc put a plan together, and yeah. So that's kind of how the progression went. I remember you asked Brother Gil what was kind of that moment, and I have to say my brother always climbs Mount Washington every year, and I've climbed it some, and it got to the point where that was out of the question, and my daughter was wanting to climb again. I climbed with her when she was younger, and she was wanting to do Mount Washington again, and I was like, it killed me to say no to my little girl that was grown up now and wanted to still go Mount Washington with me and head up the Lion's Head or down to Tuckerman's or up the Huntington Ravine. And I had to say, I can't do it. And that just killed me. So I was like, I've got to address this knee pain. And so I'm so thankful that I wandered in there to, set up an appointment and went in to see the doc and Mao and all the good folks there. So.
Yeah, and so I have to emphasize that when most people come to the office, a lot of them haven't had non-operative treatment, right? And so that's the first thing that we try to do. We try to treat our patients non-operatively and not jump right to the knife. So, what sort of treatments did you have? Did you have injections? Did you take meds? You heard Shawn was saying he was taking a bunch of ibuprofen for a period of time before surgery. What things did you try? What did you find worked for you? What did you find didn't work for you, in the beginning?
Well, I'll be honest with you. I put up with a bunch of pain. And I used to take the ibuprofen, but I never had the shots and all that. And I know that, you know, when I showed up, that was like, usually that was the program that you went through some other stages before you got to surgery. But I think I hate to say it, but I think I grin and bared like probably past some of those stages, and I really didn't have any pre things done like cortisone or different, you know, therapies and stuff. I mean, I was taking a fair share of ibuprofens, you know, but that was it. I mean, you know, so.
Yeah, I would also emphasize that you're not a normal patient. You have a very high pain tolerance, extraordinarily high, I would say. And you sort of blasted through it to the point where you just came in and you were quite crippled.
Yeah.
But sometimes those injections and the physical therapy, they really do help. And that's something that we try to emphasize in general. But I remember you coming in because you have a very big personality. I remember you coming in and thinking, I don't think anything's going to help him, but surgery. So you decided to get both knees done at one time. You know, when we do both knees at the same time, sometimes there's a little bit increased risk. So we like to have a little bit healthier patient when we're doing both knees at the same time. How did you sort of work that out in your mind, like whether you should get one or both done?
It was kind of funny. I had just really bad pain in both. And I remember having a conversation. I wanted to get them both fixed, and they said, "Oh, you're really heavy for that." And I am a big guy for sure, and you know, and definitely too heavy. So they said, "Well, let's look at this chart." And I don't know if it was Mal or somebody looked at the chart and said, "Hey, it looks like you need to be 39 pounds less than you are now to be able to get two knees replaced." So at that point, I said, "Well, then, yeah, definitely." I said, "When's the surgery?" And it was, you know, I don't know, a month and a half away or something. I said, "Well, definitely sign me up for both." So it wasn't but about, you know, when they call you right before the surgery, they like kind of the pre stuff, you know, when to check in and do all that. And they started talking to me like I was just going to get one. And I said, "Oh, I'm down for two, you know, both knees." And they said, "Oh, well, you know, you would have had to have lost 39 pounds. And I said, "Well, right now I'm 43 pounds less than when we spoke." So they said, "Oh, well, then we're doing both." So I had to kind of kick it into the old wrestling days when you had to lose weight. So I lost 43 pounds, and because I was 330 pounds at that point. So I had to get down quite a bit, and so that I could get two, but I really wanted to get both of them straightened out. And I'm really busy, you know, so I thought I wanted to make sure I took care of them both at the same time. Didn't have to take two of my seasons off when I get a break, because you know, I get a break every year after the busy season, and I just wanted to get them both taken care of.
Right. Well, thanks for that. One last question before we move on to what recovery was like. One of the participants in the webinar wants to know, what was your knee pain like before surgery? Was it like shocks or bolts of stabbing, knife-like pain, or was it just a dull ache? What was your experience with the pain before surgery?
I wouldn't say dull, but it was constant. I wouldn't say dull. I had some pretty serious pain. I was always aiming for a chair, trying to sit down, but my work is super active. I'm up all day long, you know, in the butcher shop, unless I'm doing tractor work, and climbing in and out of the tractor got, you know, extremely painful. So yeah, I had a lot of pain prior to my surgery for sure. And I wouldn't call it just a dull nagging. It got pretty serious ultimately before I had my surgeries.
Right. So that kind of drove you to the point where you said, "Listen, I think I'm going to get them replaced." So you came into the hospital. I think you had your surgery at the specialty hospital in Bensalem.
Yeah.
And if you want to tell us a little bit about that experience, and then sort of what life was like in the first 2 to 4 weeks after surgery.
Okay. I had a great experience at the hospital. I was shocked that the hospital is right in Bensalem. And I didn't quite understand. I did ask some questions later, but I didn't quite understand how that actually the doctors have the hospital. So I think that makes a lot of sense, because who cares about the patients more than the doctors? So like I did share that once. You probably don't remember, but that was one of my best like hospital experiences I've had, because I mean, it was just night. I mean, it's so set up for just what you need, and there's no like infection and sick people there. It's just like you go in, you have your replacement. I mean, everything was great, even down to like the food. I mean, the care. It was a great hospital experience, and it was so close, right in Bensalem. I didn't have to go into the city to. Now I know a lot of your patients do go into the city, but I was really pleased that we could do this local.
That's great.
So I had a great experience. Oh, and I'm sorry, I didn't answer the second part.
No, that's okay.
Basically, right after my surgery, it wasn't quite a full 24 hours, and we were walking down the hallway, and at first the lady's like, we'll walk halfway down, turn around, come back. And I honestly, I don't know if it's the medley of medication or whatever that you put together, but literally both knees replaced, and I'm walking down the hall, and I'm thinking to myself, why are we turning around halfway down the hall? Because this lady's going with me. So I said, let's go down the end, and we walked down the end of the hall, and there's a room off to the left there where you had like some exercise stuff, which I'm sure was supposed to be for later on, and they had a little set of steps there, 3 or 4 steps, and she sees me looking at that, and she goes, do you want to try the steps? I'm like, yeah. So we went up and down the steps, and I remember thinking that you were able to do that, and literally before one full day, like a 24-hour day, I was going up and down steps with both new knees, and I was just amazed. I was so blessed. Yeah, for sure. Mm-hmm.
And then once you got discharged from the hospital, so what was that experience like? So you go home, and sometimes it gets a little bit stiff afterwards. And actually, one of the questions on the webinar is, how long does that stiffness sort of last after the surgery? This particular person just had surgery in December of last year, so they're still early in their recovery. How long would you say you had some, significant stiffness before it eased up?
Well, I think in the morning after sleeping, it was a little stiff, but I didn't really hold back real long before I got back, into some daily stuff that I need to be doing. So, I'd say I remember at 10 days, I probably shouldn't have, but I got into my tractor, which I didn't like climbing. Don't tell Dr. Austin on this.
I won't tell him.
No, but I got up in my tractor after 10 days because I needed some tractor time and I needed some things done. And honestly, it was really not a problem. Now I know that probably wasn't the recommended thing to do, but it worked out for me. I probably was a little bit too quick on that, but it didn't set me back any, praise God. So very thankful. And I mean, in the mornings for a while, it was a little stiff in the morning, especially my left side was a little stiffer in the morning for some reason. But I had a great recovery, honestly. Very thankful.
Well, great. Thanks for sharing your story. So this is what we did to you. So this is the basic type of implant. There's a metal implant that goes on the end of the femur. There's a metal implant made out of titanium that goes into the bottom part of your or in the top part of your tibia. And then there's a plastic liner that goes in between those. So essentially we're giving you metal and plastic cartilage. And this is what your x-rays look like. You have the femoral component here, you have the plastic there, you have the tibial component, and this is sort of the bone grout that we use for some of our implants to hold the replacement in place. So that's pretty much what it looks like on an x-ray. So just want to remind everyone, if you have a question for Shawn or Dwight or myself, just hit the chat button there, and then you're able to type your message in there. So, Shawn, you mentioned during your recovery, the first couple of days were the worst. One of the participants here is asking, on a scale of 1 to 10, how bad was your surgical pain at its worst in that first couple of days?
At its worst, it would have been around 9 or 10 easily, because by moving around, I could feel something, but yet I didn't know what it was. I could just feel this pain every time I'd even move around. So I'd say around maybe 9.
And how long did that last for?
That lasted, well, also, I was taking the painkillers, which did help, right? But I'd say about a week, and then it eased up so much. It was then down to probably maybe about 3 or 4 after about a week.
Okay. And then Dwight, what about you? Now, both knees is a tough road usually. So how would you say your pain was from a 1 to 10 after knee surgery?
Oh, right away, I had pain, but I'd say I kind of got a number on it. I guess, I mean, it just, that first week, I guess I had, some pain and stuff, but I think after 2 days, or the second day, I didn't really take the pain, regular extra painkillers, because I think partly because I got right into movement right away, I just probably didn't get as much pain as if it got stiff, and then it was. Does that sound right?
Absolutely. So I think one of the biggest challenges patients face is the balance between sitting around too much and getting stiff versus doing too much and maybe climbing on your tractor per se 10 days after surgery and causing some inflammation there. So that's a balance. But a lot of people find that when they move around just the right amount, it really helps with that stiffness. We also do a lot of research here at Rothman, and one of our primary areas of focus is pain management. We try to give patients non-narcotic medications to reduce the amount of narcotics, because we all know there's an opioid crisis in this country. So we try to manage your pain as effectively as possible, because not only is it the right thing to do, but it also helps with your rehab while trying to minimize the amount of narcotics that people are taking afterwards. And then you minimize the narcotic-related side effects like nausea, and just not feeling right. So that is a huge area of emphasis for us, because it allows us to get the patients moving fairly quickly. One of the other questions, Shawn, about hips is that one of the patients worry about leg length discrepancy. And so I'll let you describe what you felt post-operatively, but most patients, their leg lengths, there's obviously specific situations, so it's hard to address for each individual person. But most of the time we can get your leg lengths within a few millimeters. Sometimes that's not possible. And it's one of those questions that you should ask your physician or surgeon when they examine you, is that, do you think you'll be able to get my leg lengths about the same? Because sometimes it's not technically possible. And when we do note that, it's one of the things that I emphasize to patients, like, listen, it may be a hard time getting your leg lengths to be about the same. An example that everyone can understand: if you have arthritis on both of your hips, and we only replace one, well, you're probably going to be a little longer in the hip that we replaced, because we were restoring sort of that height back to your joint. But Shawn, what was your experience with leg lengths and in the immediate post-operative period?
Before the operation, whenever I would walk, I was walking with a limp, and I actually felt that my left leg was a little bit shorter. I'm not sure why, but every time I'd walk, I was walking like a duck, because we actually have a pet duck. So I'd walk like from side to side, and I was curious, which about number one, I'm 5'10". I'm sure some people are 6 foot, maybe 6.5 foot. So how do you determine what joint you actually put into the person?
So that's a great question. I'm going to try to go back here on the presentation and show you your hip here. So what we generally do is there's a bunch of sizes available, and we digitally template every patient's x-ray prior to surgery. And that helps us size the socket here, there.
Okay.
It also helps us size the stem. And we can also measure how short you are from a hip perspective preoperatively, so we can figure out which implant will best recreate your anatomy. So that's how we generally do it.
Okay.
In terms of the how we get the implant in, which was another question. Do we sort of, they put in quotes, kill the femur bone? No, we don't kill the femur bone. Actually, after childhood, much of your bone marrow is not made from the long bones like the femur. So this is actually inserted sort of like a blade into your femur, and the bone grows onto it. But there is no deficit in the making of any of the blood cells that are necessary, because in most adults, the long bones aren't the major source of those blood cells, to answer one of the questions I see in the chat. Now, I get a lot of questions about leg length discrepancies in knee replacements as well. And from a technical standpoint, we don't have much control over the knee, whereas we have somewhat more control with the hips. And with the knees, we kind of just have to straighten the knee out, and the leg lengths are what the leg lengths are. Now, Dwight, you're not a short man, so I don't think you need much more height. But what did you find with the experience in terms of changing your alignment of your leg? Like, what did that feel like? And did you feel like you gained some height back?
I didn't really notice a lot of height gaining, but I did have like some habits that I developed before surgery, where, you know, how I went up and down stairs, and I had some very, you know, odd ways, because certain, just to alleviate the pain. And honestly, it was very important that I tried to get rid of those habits and start walking up and down stairs normally. And you know, for quite a while afterwards, every once in a while, I'd find myself going back to the way I used to do stuff, just out of memory. So leg length wise and all that, I think it didn't really affect a lot, but I did know that there were certain ways I did things that were because of the pain in the knee, and I kind of had to rethink and retool and begin to operate in a different way when I had joints that didn't hurt anymore like that. So that was something, and particularly going up and down steps, or going up and down the ladder that is on the side of the tractor, or doing any of that kind of stuff.
Yeah, so a lot of people have to get used to the new alignment. They have to get used to not having as much pain. And the body sometimes goes through different phases. Like, for example, you may not expect to get ankle pain after your knee replacements. And people are often wondering, why am I getting some ankle pain? Well, it's because your alignment's changed, and now the weight is falling through your ankles in a different way. So there's often some unexpected things that can happen. A lot of the questions on the chat now are sort of like, can you get surgery, hip or knee surgery done and go home afterwards? And I would say absolutely. That's the best place for most patients. Now, there are some patients who aren't able to go home because they are severely debilitated. But most patients, even those who live alone, can certainly go home after hip and knee replacement surgery. Again, everybody's different and every situation is individual, and I encourage you to talk to your surgeon about whether it's appropriate or not for you to go home. In terms of rehab after surgery, lots of patients can just follow an exercise program and do well, but that's not for everyone. So in our institution, about a third of our patients will go to formal physical therapy with a therapist afterwards, but 2/3 don't necessarily need to do that. And that's the discussion you should have with your surgeon and the care team afterwards in terms of determining whether or not actually going to therapy with a therapist is going to be helpful. But when you hear, oh, I'm going to go home afterwards and I'm not going to get therapy, that's not exactly true. You're going to do a lot of therapy. It's just that it's going to be a self-directed program. And if you need something on top of that in terms with a therapist, that's certainly something that you should discuss with your surgeon or the care team helping to take care of you. There's some other questions about surgical approaches. So Shawns' surgical approach for his hip was through the front. What I would tell you, it's called the direct anterior approach. What I would tell you is that there were 4 great surgical approaches for hip replacement surgery. It's a wonderful operation, no matter how it's done. Each individual approach has its own pros and cons. And that's something you should discuss with your surgeon at the time. But in general, all 4 are wonderful ways to perform a hip replacement. In terms of knees, There are a few different surgical approaches, and I would give you the same answer. In the literature, in the studies that we look at that are well done, prospective randomized studies, there's really not much different between the different surgical approaches, the different type of implants. This is really, hip and knee replacement are some of the best operations that we have in medicine, and it's less about necessarily how it's done, but it must be done right, and it must be done by a patient must be done on a patient who is engaged and wants to participate in their recovery. So I know so much is made of marketing with different approaches, but I think a little bit too much. I think these operations, if they're well done by an experienced surgeon with a patient who's engaged in their well-being, can do very, very well. Dwight, do you have anything to add about your recovery? Like, for example, some patients are asking about clicking. Do you have clicking in your knee?
Every once in a while, when I move a certain way, I can hear a click, and repeated. Like if I think it's kind of funny. So sometimes it'll make a click and then I'll move it some just to hear the click. But as a general rule, I don't really pay much attention. I mean, once in a while, a certain way I'll be sitting or the way I moved it, I hear a click, if it's quiet around, and I'll move it a couple of times, just like, wow, but or sometimes when I go for a walk, now, see, I can do these things. I go for a walk once in a while with my bride and my daughter, and sometimes I can hear it clicking a little bit, but hey, that's no worry compared to the alleviation of the pain that I have. So.
Yeah. Yes, and clicking is very common afterwards. I would say that painful clicking is something maybe to talk to the surgeon about, but clicking that's not painful, I wouldn't worry about that. I wouldn't worry about that too much, because it's metal and plastic, and you can see on this image here, if you have a little bit of separation between the metal and plastic, which is normal, by the way, in a knee, you may get some clicking because it's a hard bearing surface. Now you have metal on plastic as opposed to your native knee, which has cartilage on cartilage. So it's not something to be concerned about unless it's painful. And in general, you don't hear much sound from hips. Have you heard any strange noises coming from your hip, Shawn?
No, I haven't, except that I will say one thing. Before I had the hip done, I had so much pain. We actually have a wood burning stove, and I'm always out cutting wood. So before I had my hip done, I would be out in the garden. Every little bit of movement, I would have pain. When I had my hip done, about a week and a half, 2 weeks, I started cutting wood again. But what I actually feel you should do with a hip replacement, you should give it time to heal. Don't just think because I have no pain, I can jump back in a week or two and just do whatever I was as if I never had any pain. I actually feel you have to give it time just to grow and just to get it better again. And that's what I felt, because as I said, 2 weeks after I had no pain, I said, great, I can grow, I can split firewood, I can do this, I can do that. So one day I was out in the garden, maybe from 10 in the morning to 6 in the evening. Came in and said, God, my hip is paining me. So I got the ice pack, I put my legs up and I put the ice pack on. So the following day I said, I'm not going to go out as long. I'm going to go out a little bit and start building up slowly.
And in regards to that, one of the participants here wants to know, how much time did you spend each day with the post-operative exercises?
The post-op exercises, which is before the operation?
No, afterwards.
Sorry, okay, afterwards. I actually had a list of all exercises to do. So every morning I would get up and I would do my exercises. I would add in a few other little ones. Like I'd say after about a week, I start on my staircase, and before that I would walk up one step at a time for me to go up and down the stairs. So I said to myself, why don't I walk up one step left and right, and I start gradually adding in more steps. So I'd say maybe 2-3 weeks, I was doing a little bit more exercises, stretching it a little bit, because naturally after an operation, the muscles around your hip are under so much stress that you need to just loosen them up again.
Yes, and I would say that's a very typical experience for most patients. If I can pull Moy or Marilyn in, What are some of the common questions that you get from patients in the post-op period, or even before surgery, that they're concerned about? Because I'm sure that many of the participants on the webinar here will have those same kind of questions, and I may have skipped over something. So, Moy or Marilyn, do you want to kind of cover that?
Sure. I would say, this is Marilyn, by the way. I would say patients, ask about when can you drive after surgery, whether it's a hip or a knee. A lot of patients, like you had mentioned earlier, Dr. Austin, have concerns about taking narcotic pain medications. So those are pretty much the typical questions that we get overall with either hip or knee replacement surgery.
Yeah, and we, like I said, we try to avoid the narcotics. One of the questions I'm looking at right now asks if you're allergic to codeine, what options are available that are non-narcotic. And so, we have a cocktail of medications that we use, some as simple as Tylenol. We use meloxicam, which is a anti-inflammatory that's somewhat protective for your stomach. We may use a muscle relaxant or a nerve stabilizing medication, and we find that the cocktail together, we recently published a study showed it reduced the narcotic intake by about 1/3. So it is really important to get adequate pain management afterwards. Not everyone needs to take narcotics, and pain management afterwards is actually quite genetic. There's a genetic factor to it where some patients need a lot of medications post-operatively and some don't. Like, look at Mr. Ely. At bilateral knee replacements, classically described as very painful, and he really didn't need that much in the way of pain medications. I think part of that's because he's a farmer and he's a pretty tough guy, but I think part of it too is he's been genetically blessed not to have a lot of pain. Shawn only had pain for a week after surgery. Again, lots of people will have pain for a longer period of time. So obviously Shawn and Dwight aren't genetically predisposed to being sensitive to pain. And it's not your fault if you're sensitive to pain. We know that now. There's a genetic predisposition. Our job is to find the right combination of medications to make the recovery tolerable for everyone. Moy, do you have anything to add?
I think our primary concern with the patients is how we're going to manage their pain after surgery, and we're very honest on what to expect after surgery. So we try to keep you as comfortable as we can, and using the multimodal pain medication protocol is really helpful in meeting the narcotics. But Dr. Austin always tells the knee patients, you're going to take them for 2 weeks, and that's just a period of time when it's the most uncomfortable. It's a surgical pain, pain where it's going to get better type of pain, not like this awful arthritic pain. So, that's one of the primary concerns with our patients. But we always promise, we'll get you through. You just have to weather a couple storms. But in the end, there's a pot of gold, but sometimes it just takes a little bit to get there.
Yeah, and one of the other topics that patients are often bringing up is the fact that, how much support do I need afterwards? And of course, everyone is different. They come into surgery at different levels of strength and in different support systems. But I think one of the keys is for patients to realize that you're not sick. We had this sort of feeling back in the late 90s and early 2000s that when you had a replacement, you came in, you were in the hospital for 3 or 4 days, then you went to a rehab center for 2 weeks or so. And sometimes patients were away from home for a month or even 6 weeks after their surgery. And slowly that takes time, and I think pain management has a lot to do with that. I think advanced physical therapy protocols have had a lot to do with that. And so we're away from the so-called sick model now. When you get your replacement surgery, you're kind of in there for repairs, but you're not sick. So no one has to attend to you, but it's certainly nice to have someone checking on you. And I don't know, Dwight, and I'll go with you first, and Shawn, I'm sure, Dwight, your wife was very helpful, and Shawn, yours as well, but how much help do you think you really needed early on?
Yeah, my bride was support and gave me support. One thing I did like were the follow-up visits. I remember walking in that visit after one of my first visits. I saw Mal spotted me, and I don't think she knew who I was. I came in a pair of shorts, and I strolled in there, and and then you have those follow-ups, which are good. I felt really good that you got us in there and answered questions and stuff. But I had support, at the farm, but I mean, I didn't really need a whole lot. I mean, I still went up and down the steps and did all that. So, which I think was important to get right back in again and not do a lot of just sitting around, because I think part of the reason I healed well was because I kind of got right back, to doing, active. I was relatively active pretty quick.
Great, great. And Sean, similar sort of experience?
Yes, my wife was very helpful before the operation and afterwards. Like whenever we would go out for a drive, she would say, you have to sit on the seat first. What I was trying to do was just get right into the car by lifting my left leg in. And because my wife had a hip operation many years ago, and they actually did the hip replacement from the inside, not from the front like I did. So she had staples put in many years ago. So she knows. So she said, Sean, when you get into the car, sit in the car first, then lift your leg in. Whereas I had great support there.
Great, great. It is nice. It is nice to have support, but we do have a lot of patients who live alone who are able to go home. Sometimes those patients need to stay in the hospital for just a little bit longer to make sure they're safe to go home. And that's our biggest concern when people are leaving, is just making sure they're safe and able to take care of themselves, especially if they don't have a support system in place. One of the other questions was about blood clots afterwards. I think that's one of the more serious things that people worry about after hip and knee replacement surgery. The good news is these days is that most patients can take baby aspirin 2 times a day in order to avoid blood clots that go to your lungs, which is what we're really worried about. It's called a pulmonary embolism. There are some patients who have medical conditions or are higher risk that need something stronger, more aggressive. But the good part about aspirin for most patients is that it reduces the risk of blood clots, but it also is less likely to give you bruising and bleeding at the surgical site, which can lead to infection. So we've been able to change our protocols over the last 10 years or so to just using baby aspirin. Again, we've been at the forefront of research on this to help make the standard care really across the country. So yes, we are concerned about blood clots, but aspirin is an effective way to reduce your risk of blood clots. And we usually keep you on that for about 4 weeks after surgery. So that's just to address the concerns about blood clots. So I think we have a couple of minutes left here. I have to give a shout out to my other patients that are participating here. They logged on even though they don't really have the problem anymore, and they're thanking me. So I really appreciate that, as well as my Aunt Sharon, who's also logged on there. She doesn't need any replacement. So I appreciate everyone being on your supportive words. So, I think we'll wrap this up in a minute. If you're interested in seeing one of the docs at Rothman, I can give you some info here. Sorry, I'm going through the slide again. So it's pretty simple. Our website is rothmanortho.com, where you can reach us at 1-800-321-9999. And I'm sure that Leslie and Janine, who are also on, have some parting words for you. So thank you, everyone, for allowing us into your homes. A special thanks to Mr. Dwight Ely, visited Ely's farm, and Mr. Sean Gill. Sean Gill and Sons for plumbing, if you have any plumbing needs, particularly if you have a condo in Philadelphia, right?
Yes.
So thank you for joining us, and thank you so much for opening up your experience to everyone who's participating, and for everyone who will watch this sort of on demand later. So I'm going to turn it over to Leslie and or Janine to bring us home.
Thank you, Dr. Austin. So in addition to being a wonderful joint replacement surgeon, you're also trying to steal my job. So thank you. If anyone is interested in scheduling with Dr. Austin or another physician here at Rothman Orthopedics, the best way to do so is on our website, rothmanortho.com. Right at the top, you'll see a button that says make an appointment. You can submit all your information right there on that screen and someone will reach out to you for coordinating that. If you prefer old-fashioned way, you want to give us a call. Most direct number is 800-321-9999. I did also enter that into the chat. Just as a reminder to everyone that joined us tonight, we did record this event and everyone will be receiving the recording via email to the address that I sent the link to join us tonight. So without further ado, thank you, Dr. Austin. Thank you, Mr. Gill. Thank you, Mr. Ely. Thank you, Marilyn and Moy, for joining us. And thank you, everyone. I hope you found this very informative and educational. And have a great evening.
Great job, Liz. Thank you.